All right, good afternoon. Just a reminder, please silence your cell phones. We have two speakers now. First up is Dr. Alysia Cohen. Alysia Cohen is an assistant professor and clinical education coordinator of athletic training at Weber State University in Ogden, Utah. Her academic background includes a Bachelor of Science in Exercise and Sports Sciences with an emphasis on athletic training from Oregon State University, a Master of Arts in Education from Boise State University, a Master's of Public Health and Doctor in Physical Activity and Health from Oregon State University. Alysia currently serves as the RMATA Annual Clinical Symposium Programming Committee. Thank you. Her research includes physical activity behaviors among youth sport participants in associations with sport enjoyment and injury. She enjoys exploring the outdoors with her family and friends. We also have Valerie Herzog. She serves as the professor and chair of the athletic training department at Weber State University. She completed her bachelor's degree in athletic training from Alderson Broaddus College, her master's degree in athletic training at the University of Virginia, and her doctoral degree in higher education administration from Marshall. She's currently the chair of the legislative committee for the Utah Athletic Trainers Association and chair of the education committee for the Association of Schools Advancing Health Professions. She's a fellow of the National Academies of Practice, the Association of Schools Advancing Health Professions, and the Northwest Commission on Colleges and Universities. She also serves as secretary of the RMATA. Please help me in welcoming Drs. Cohen and Herzog.
Thank you. Thank you all for being here. So Alysia and I did this workshop at Weber State, a couple of years ago. We were going to bring it here with the goal to bring it to all of you and train athletic trainers to become instructors. So this is a standard presentation. It was developed by the American College of Surgeons in cooperation with some of these other groups that contributed, including American College of Emergency Physicians, Emergency Medical Technicians, and Committee on Tactical Combat and Casualty Care. So by attending this session, and if you also come to one of the workshops this weekend, there are 2 tomorrow and 1 on Saturday, then you can leave and you can go online and you can register as an instructor. And then you can go back to your places of business, your communities, your schools, and you can train others using this. We have added quite a bit to the presentation, so there's a standard one you can download online, and all of that is incorporated here. But Alysia and I have stepped it up and made it a little more evidence-based and given more literature background, because everybody loves that stuff, right? So we will provide more information at the workshop about how to become an instructor if that's something you're interested in doing. But that's really what we're hoping to do by bringing this here. And if you do come to the workshop, there is a fee for it, but you're going to go home with a tourniquet and a quick clot hemostatic infused gauze pad. So the fee just pays for the supplies you're taking home, basically. So just some disclosures. There may be some images during the presentation that are a little disturbing. They're really not that graphic. We didn't go that route. And neither Alysia I have no conflicts of interest to disclose. So why do we want athletic trainers to do this training? Why should you want to do this training? The number one cause of preventable death is bleeding after injury. And so just a little background on that. So hemorrhagic or hypovolemic shock, those two are kind of used interchangeably, typically begins when someone loses about 20% of their blood supply. So if you look at an average person who weighs about 70 kilograms, they typically have about 5 liters of blood. So if they lose about 1 liter of blood or 20%, they're probably going to go into shock. However, and this is a new word that I learned, exsanguination is death due to excessive blood loss, and that's when you're losing more like 40% of your blood, or again, for that average body size, about 2 liters. Now, of course, we would never expect somebody on the side to measure that, but 2 liters of blood is a lot of blood, right? Even 1 liter of blood is a lot of blood. So, if you see a lot of bleeding, that's going to trigger you to maybe use some of these skills and techniques that we're going to teach you. Another reason to consider doing this training, just thinking about time-wise, the average time for someone to bleed out after a serious trauma is about 3 to 5 minutes. The average time for a first responder, not us, but we're talking about an ambulance to come or advanced medical care to arrive on the scene, is 7 to 10 minutes, right? So this is why it's really important for people on the scene to be able to implement these skills and procedures to save lives. And it's about 40% of trauma-related deaths worldwide are due to bleeding, right? So this is a lot of people, big numbers. In athletics, it's a little bit lower, and if anyone is looking for a good epidemiology research study, there really isn't anything out there that I could find. I even reached out to some others who've published on the topic. Do you know any epidemiology data on severe bleeding in athletics? And it doesn't exist yet, so there's a gap. But they have done some research. They did kind of a self-reported with ice hockey athletes, and about 2% of them did report having skate cuts to the neck. Most of those were not severe bleeding, but some of them were. And if you look at this picture, I'm trying to remember his name, Teddy. This is from January 2022. He was up in the Newark area, and he actually did not survive following a skate cut to the neck. No one there was able to treat him soon enough, and so he passed away, and that's just very recent. Sometimes in athletics, we deal with open fractures. Sometimes this can happen in a skiing injury. We can get severe bleeding and other kinds of random injuries that we see sometimes in athletics. But then there are other situations that as an athletic trainer we might find ourselves in. The New York Times reported 9 mass shootings just over the March 18th to 20th weekend of this year. And they define that as 4 or more victims, right? So 9 in one weekend, right? So unfortunately, the odds are high that at some point in our career, we might be a witness to that, right? Caravan and bus accidents. So this picture is just from this month even, where there was an athletic team, and a lot of us travel on buses and vans or in cars with our sports teams, and they could get in an accident, and we could be the one on the scene providing care for that. And then, of course, the Boston Marathon bombing, which was a huge tragedy, but a lot of severe bleeding following that event. And then, there was a stadium collapse in Brazil in 2007, and that could happen anywhere, right? So for all these reasons, just trying to drive home the point of it's likely in our careers that some of us are probably going to encounter severe bleeding and might be able to save a life if we knew exactly what to do, and it's not that hard. So again, just to reinforce, where can I use this training? It could be at work, it could be in a school, it could be at home, it could be in your own car or a car accident. Sometimes it could be from lightning or even a mass shooting. So at this point, I'm going to pass it to Alysia, and we'll pass it back and forth a couple times so you don't get bored of us.
It's to check if you're listening once there's dead air. Do we go this way? Oh, you do. We're going back.
I'm sorry. So I had it written down, I'm to slide 9, but of course they don't tell me it's slide 9. So the trauma triad of death, I know this is kind of a dark slide, kind of a dark presentation overall, but kind of 3 major things happen during severe bleeding that can cause the patient not to survive the incident. The first of which is hypothermia, and you can imagine as your body is starting to bleed out and lose 1 to 2 liters of blood, it wants to go into self-preservation mode, right? So it's going to shunt blood to the extremities and focus it on the heart, lungs, and brain, which causes the athlete's core body temperature overall to drop. The other thing that happens, which is interesting, is the body starts to shift away from aerobic metabolism over to anaerobic glycolysis, which, as we know, creates a state of acidosis, and that can accumulate and become significant and really actually cause a significant drop in the pH of the blood. And then the third thing that happens is coagulopathy, and because of these other incidents and some other things going on physiologically, that the body actually has a decreased ability to form a clot, right? And so all of those things coming together can actually, unfortunately, result in a death of the athlete or not able to survive the incident. So, and the largest contributing factor to all of this is uncontrolled bleeding. And so really the purpose of this training is to teach you how to control severe bleeding. So now I will pass it to Alysia. Sorry about that.
Okay. So as Val mentioned, there's various areas in our daily lives and our work environments that we might encounter such emergency with severe bleeding. So the goals of Stop the Bleed are, 1, to identify a situation that deems the severity in which we need to take action using these skills, but also to follow that with, okay, well, what do we do then? How are we going to stop the bleeding from occurring or control the bleeding in some cases? So we look at pressure skills or pressure procedures, as well as packing plus pressure, and then kind of the last line is application of a tourniquet. And so we'll talk a little bit about each of those. Before you, of course, are going to respond, we always want to think about when we're responding to emergency situations, checking the scene, checking for any type of hazards that could present a safety issue for us as responders. So if we become a victim, then no longer can we respond to the others that are possibly also needing care, and then we become part of that pool of people. So it's really important to just stop, check the scene, look around, and then take actions appropriately to ensure that you're safe in approaching that patient. With that as well, you want to consider precautions for bloodborne pathogens. There are always situations where you just don't have gloves or certain personal protective equipment on you to create that barrier, but whenever you can, apply those gloves. And if it's in an athletic training setting that you're having a severe bleeding situation, oftentimes we're going to have the necessary supplies on us. So not only protecting ourselves by not entering a scene that's unsafe, but also protecting ourselves against hazardous agents that could be an issue in the future. So steps in general are an ABC protocol. So A is alert, and in the United States we have a system for emergency response, and we dial 911. Following that is to basically identify the bleeding, and I'll go into more detail here in a few slides on these, but identify the bleeding and then work to control the bleeding through compress or other techniques. So this is just kind of reiterating in the 911 call that we are calling 911. Know your location, of course, and providing information to the 911 operator. It's best to stay on the phone with that individual, but if you need your hands free to provide care, maybe putting your phone on speaker, setting it to the side so that you can continue communication with that 911 operator, giving them the information that they need in order to send the right units and the right medical personnel to help with that. I think that's working. Yep. And then moving into bleeding, find the source of bleeding. And we want to look for, some continuous bleeding that's going on, large volume, potentially bleeding that's occurring, and pooling of blood. Those could all be indicators of, bleeding is somewhere. But sometimes we have to also consider that it's not always in one place. So even though maybe we've identified a pool of blood or continuous bleeding from one location and we are stuck on that, we don't want to get tunnel vision too soon, because there might be other areas of the body that are also bleeding, and maybe they're minor compared to the one that you have already found, but it could also be a second severe bleeding site too. So try not to just focus on finding that one and then stopping, but doing the whole scan of the individual so that you can find all the sources. Clothing might hide that, so if you need to lift up, remove, so forth, that's the best approach, is to get a clear view of the skin and the tissue. This slide here is just showing certain areas where bleeding is common to occur. Arms and legs, of course, and when we look at tourniquet application, this is really the main areas that tourniquets can be applied is a limb location. When we get into the neck and the armpits and the groin and these more junctional areas, these are not areas that we can easily tourniquet, so a lot of that's going to be with compression, with the pressure and the packing situation there. And then the trunk, of course, is the same thing, where we can't put a tourniquet in that area, so we're going to do a lot of compression activation there with the body. So we'll move into some pressure, and this is actually where I hand it back to you.
Thanks, Alysia. So just like we learned in any general first aid, direct pressure is the first point we're going to first, kind of plan of attack. But if you see that it's a very large gaping wound, you're not going to do pressure first. First, you're going to do packing and then apply pressure over the packing. And so initially, if it's a smaller wound, this works great. But if not, we're really going to need to pack. And if you can start this video, it does not have sound, so don't worry about sound. But this first video is just showing more of a pressure without packing, and we do have these training devices that we'll have at the session. So just putting a lot of gauze or padding, and you notice she's using a t-shirt. If you don't have sterile gauze, or if you don't have even non-sterile gauze, use whatever you have available. And 2 hands really using a lot of pressure directly over that wound, and then holding it for at least 2 to 5 minutes until you can get the bleeding to stop, or potentially more. If it's a large wound, you're gonna need to pack the wound first. And so you can see by this picture on the upper left that you're not being gentle, right? You really need to stuff that packing down into the wound all the way. I mean, your fingers, you can see in that picture, the fingers are going down into the wound. And you are gonna pack in that gauze and pack in that gauze and continue packing it in as much as you can get in there, a little bit at a time, until you can't get any in there anymore. And then you're also going to apply additional on top, and then you're gonna apply the pressure as well, and hold that for still another 2 to 5 minutes. Okay, so if you just do the lower part, if you just put a little gauze and hold it on a major large wound, it's not gonna work. It's not gonna be effective. And we've got another video just to demonstrate this. And you'll notice in this one, they're actually using a gauze pad that's embedded with hemostatic agent, which we'll talk about in a minute, the quick clot. So you'll notice they've got that big packet of gauze, and they're not gonna try to stuff the big packet in all at once, because it's not gonna work. They're gonna do a little bit at a time and stuff it in there, and just continue to stuff it down in there until they can't stuff any more in. And then once it's full, then they're gonna put additional gauze over top and really hold that pressure down for a significant amount of time. So again, you can see, and you'll see this in the workshop. Sometimes you'll think, oh, I can't possibly get any more in there, and all of a sudden you can. And then additional gauze and lots of heavy pressure on top. One of the things you'll notice that's not in these slides is elevation. The recent research on elevation is kind of like, weak evidence. Maybe that doesn't really do as good as we thought it did, right? So that's why you'll not see that in this presentation or in these recommendations at this point. So packing, you can do packing pretty much anywhere in the body. So you can do it in the extremities, you can do it in these junctional areas, and you can also do it in the core of the body, right? And as Alysia mentioned, on the extremities, a tourniquet works great, but you can't use a tourniquet in junctional areas or in the trunk area. So packing may be, depending on where the wound is, it might really be your best option. So if you are selecting a hemostatic agent, so you want gauze with an embedded hemostatic agent to help better control that bleeding, there are new ones on the market all the time, and this is changing very rapidly. We're gonna recommend one particular one today for a lot of these reasons, but I wanted you to have this information because maybe there's a new product that comes out tomorrow, or there's other products that are currently prescription that now become available to athletic trainers. So this will help you evaluate the products out there and help you choose what's right for you and your setting. So some of the recommendations are that obviously the product is FDA approved for this use, that it's quick and effective control of bleeding within 2 minutes for a wide range of conditions and wounds, that it's easy to administer and not just for an athletic trainer, but remember our goal is that you go home and you teach this to teachers, maybe elementary school teachers, maybe to coaches, maybe to parents, maybe to school administrators, right? And so you want it to be, this training and this idea is that the more people who know how to do this, the more likely we are to save some lives. So we want this to be easy for anybody to use. Right? Even under a stressful condition, they shouldn't have to read the instructions. It should just be really easy to use. And then along those same lines, portable and easy to store, even under extreme conditions. So you should be able to have this product in your kit out on a hot day and not worry about it not working if you needed it in a few weeks or a couple months or even a year. And then the product should have good biocompatibility with no adverse effects. So some of the EMT literature, there's some concerns that some of these hemostatic products might end up in the bloodstream and cause adverse reactions or embolisms. And so the product should be less likely or have a low incidence of issues like that. So there are different classes of hemostatic agents. I'm not going to spend too much time on this, but just to make you aware, there are things called factor concentrators, The quick clot does this, so it rapidly absorbs water out of the blood, and it allows the blood to kind of get thicker in that area, right? The viscosity to increase, and that causes a greater concentration of those clotting factors in the blood and speeds up a clot formation to help stop the bleeding. There's also procoagulant supplementers that actually deliver clotting agents to the wound, and the fibrin sealant is one of those. And then they also have this category of mucoadhesive agents that actually adhere to the tissues and seal the wounds. Most of these are derived, especially the Hemcom. It's made from shellfish compounds. So if you have a patient who is allergic to shellfish, actually some of the literature I had read had said, they might have an allergic reaction, but I actually have my aunt lives in Albuquerque. We had lunch before coming out here, and she worked in trauma. And I said, what do you think about some of these bandages? What kind of reactions have you seen? And she said, it's not a rash. They go into anaphylaxis, and it may result in their death. So that's one of the reasons that the Hemcom bandages are actually available only by prescription. So you wouldn't want to use it on someone unless you were 100% certain they were not allergic to shellfish. The other side, though, is that they do work better if you're working with a patient who's taking blood thinners for whatever reason. These bandages work better for them than a quick clot would. Oh, whoa. I did not mean to do that. Can you fix that for me, Mitch? Sorry. Go back to the slide. Down. 28. Yep. Perfect. Thank you. Sorry. I'm going to not hold this. So this is the one we're going to be demonstrating in the workshops, and you will be taking home a package of quick clot if you come to one of these workshops. And I think there's still openings if you want to add in. Alyssa and I even increased the size, the capacity just a few days ago. So these are significantly more effective than just regular gauze for packing wounds, right? Because they do actually have hemostatic properties. And tourniquets, like we mentioned, are effective, and Alyssa's going to talk more about those, but you can't use them in all areas of the body. So the quick clot gauze uses kaolin, which activates factor 12, which assists in the initiation of the coagulation cascade, and then, as we mentioned, also absorbing the water out of the blood to increase the viscosity. And these are typically used, depending on what literature you read, some will say if you've got it and you know it's a major wound, you should go to this hemostatic agent right away. And others would say, well, let's try pressure first. But I think we'd recommend if it's a large wound and it's significant bleeding and you've got a hemostatic agent, you should use it, right, for your packing area. There was a study recently done comparing the quick clot and that bloodstock battle matrix product. And again, this is the second one is the one that's made from shellfish material. And they did a swine study, so they took these poor little piggies and did a 6 millimeter laceration to their femoral artery, and then they compared the two products. Overall, they were pretty similar, but the battle matrix did work a little bit better, a little bit faster, and maintain the hemostasis a little bit longer. It is more expensive, so be aware of that, and currently it is only available by prescription, but I wanted to present it because it's probably on the edge of being more available, and depending on your certification, you might have access to it. So the quick clot is currently available over the counter and has a very low incidence of having any kind of biocompatibility issues. So some general indications and contraindications. Part of it of all of these is going to depend on which agent you use, right? And I'm not going to talk about all of the products on the market, and like I said, there might be a new one tomorrow. But in general, we would use it for major vascular injuries and when direct pressure is not effective to stop the bleeding. But don't wait 2 to 5 minutes of direct pressure before deciding to use the hemostatic agent, because they may have bled out by that point. And anywhere, certainly in an area where a tourniquet is not appropriate to use. Some contraindications will obviously depend on which chemical you're using, which hemostatic agent, but in general, we're not going to use it in the eyes or the mouth, and typically not in the OR for surgical use. And if you have patients that are known to be taking blood thinners, some of these products like Quick Clot won't be as effective, but still better than nothing. And then some precautions. Just remember that you can't just pack the wound and walk away, that you've got to pack the wound and then still apply direct pressure for at least 2 to 5 minutes. And what you're looking for is the bleeding to stop. And we'll cover this more in the workshop, but that's your ultimate, how do you know if it's working? Well, did the bleeding stop, right? And know that some patients still may experience allergic reactions or have side effects from some of these products, but at the end of the day, if they don't survive, it doesn't matter if they got a rash, right? So you have to kind of weigh your pros and cons. So at the end of the day, our primary goal is to save a life. So turn it back over to Alyssa.
Okay, so I will talk about the tourniquet. And it's important to note that we're going in a specific order here. So we have pressure, and then we have pressure with packing, and then we move into the tourniquet. And that's the procedure that should pretty much be followed throughout any response, emergency response that you're taking. However, if you are identifying severe bleeding that is deemable to just immediate tourniquet, you can go there, but you really want to be cautious not to rule out what could be done with just pressure and packing and jumping too quickly to that tourniquet. And I'll explain why with some of these physiological effects here. Think about, but research also, the second or third bullet point I want to emphasize, research has shown that training such as this, so we're doing more of the presentation now, and then the workshop will be the actual hands-on training, has an effect on response. And that's civilians responding to civilians. In some cases, that's what we are in our everyday lives, or healthcare practitioners responding to athletes, and in our case, our patients, and what that demographic is. So it's important to know that, yes, we are trained in our skills as athletic trainers, but there's always other elements, there's always other practices that we can further our training and provide better care. And this is one of those. So this is from American College of Surgeons Committee on Trauma, which organized the Stop the Bleed. Sorry, one of the things did not save there that needed to, and I'll point that out in a moment. But this just is somewhat of a flow chart. Where do I start? Where do I go? And making decisions. So starting with, you've identified severe bleeding, uncontrolled bleeding. You're going to apply direct pressure, and via pressure using a dressing. If that direct pressure is controlled, we are somewhat going to stay there and remain there until advanced medical care arrives and we can make that transfer of care. If it's showing to be ineffective, that's where that shaded gray box showing packed with hemostatic agent should be on both sides there, those arrows, that we are going to add that hemostatic agent and pack the wound and see if some of those chemicals can make progress on the bleeding. One important thing to note is that you don't want to pack and then unpack something. So think of that, you've got gauze in there that doesn't have a hemostatic agent on it, but then you realize you have some. We're not going to unpack it to replace it. We're just going to add it into there, essentially. Okay. So if that works, then we're going to continue, of course, maintaining that hemostatic agent with the pressure. If we're not seeing any slowing of the bleeding, controlling of the bleeding, stopping of the bleeding, that's when we go into making the decision to apply a tourniquet. And we need to identify, okay, is this on a limb where I can apply a tourniquet? That's the next step. If it's not on a limb, we just continue to give as much pressure, adding more layers of gauze on top of that, thinking about the trunk location, junctional areas, to continue that pressure component, okay? Let's see if it'll go. So this slide is gonna, or the next few slides will actually walk through some of the physiological effects of a tourniquet. And some of it is, like, okay, well, do we really need to know this because this is going on in the body? And some of it is, well, once you remove the tourniquet, once a tourniquet is placed on, you're not going to remove the tourniquet. What's going to happen is there's going to be that transfer of care, and then the next practitioner, once they get to the emergency room and so forth, may decide that we need to change out that tourniquet, or it's time to take the tourniquet off and go into the next step for treatment. So once we put it on, it just stays on at that point. But there's some effects that are occurring that may be displayed, that we might see visually through presentation of signs within the patient, but also that are occurring underneath there that we aren't necessarily seeing too. So some of the immediate effects on muscle is that we have a decrease in partial pressure of oxygen, and we have an increase in that partial pressure of carbon dioxide. So if you think about oxygen is going down in the blood concentration, less oxygen is being delivered to the muscles to be able to work properly in this case. So we're starting to see, as Valerie mentioned, or Dr. Herzog mentioned, is this shifting from more of an aerobic state to an anaerobic state that, if any of you have ever done sprints for cardiovascular fitness, is only sustainable for so long until your oxygen gets depleted from there and you start to see some negative effects in terms of tissue recovery or muscle recovery at that point. So when we move to the 1 hour to 3 hours post-application, that's where we really are starting to see some of those effects happening, shifting to that anaerobic metabolism. That precursor for intracellular acidosis is starting to appear or kick in. And again, these aren't things that we're like, oh, we need to remove the tourniquet because we're too far along and we're starting to lose some of that tissue. We keep the tourniquet on, just understanding that there's these other processes that are occurring that, if this is an athlete that hopefully would be able to return to play through treatment recovery, through rehabilitation, understanding what physiological effects may have occurred because of that tourniquet application. More around that 2+ hour, microvascular muscle injury is occurring, and then this post-tourniquet syndrome really starts to become something that a patient will experience, again, once that tourniquet is removed by the next healthcare provider, where in the long run they're going to feel some swollen, some stiffness, some paleness in the limb that will be visible, and then weakness, not necessarily paralysis, but just weakness in that muscle or in that limb as a whole. And that can last up to 1 to 6 weeks. I'll go into the next slide in terms of the neurological, and that'll explain a little bit more about it too. But 6 hours post-application, you might be thinking, man, that's a really long time. But if we look at some of these school shootings and events that have happened where they've been locked down for hours at a time, it could be that that individual or that patient has had that tourniquet on for that amount of time. Is it ideal? No, we want to get them to the next level of care as fast as possible, but sometimes that's the situation that is occurring. So at 6 hours, what the literature has shown is there's muscular damage that is likely permanent at that point, lack of oxygen. And in very few cases, though, they've had to experience an amputation. So it's not if you have a tourniquet on, you're going to automatically lose a limb. The idea is we want to save a life. Let's put the tourniquet on if that deems necessary. And if we get to the 6 hours, the next healthcare, the doctors, the physicians are all going to make that decision in terms of whether or not there's a tissue to save. And much of that decision comes down to more of what has happened prior to the tourniquet that required the tourniquet, so the event that destroyed or damaged the tissue, that leads to that decision, not actually the application of the tourniquet. Looking at the nerve and the tourniquet is round in nature, so it's going to go circumference-wise, around the limb, and then it's going to be tightened down so to an extreme amount of pressure, 1,000 millimeters of mercury of pressure, and it's intensely painful to begin with. But right under that pressure point is where much of that nerve is actually experiencing physiological effect. It's being stretched. So this diagram, I'm not sure if I know how to use the laser, but if you look at the picture, it just shows the lengthening of that nerve. So much of that is just occurring right underneath the tourniquet, where there's above and below or distal or proximal to it, everything is fine within the nerve. So where that tourniquet is placed is often where they're going to see some temporary or partially or possibly some permanent effects on that nerve. But the tourniquet paralysis at 1 hour post, that's a conduction block that's going on. And again, that's around 1,000 millimeters of mercury. Mild pressure, and just a show of hands, just kind of polling the audience here. Has anybody done the blood, the occlusion wraps in terms of occluding the blood for rehabilitation? Yes, thank you, sorry. I was like, why can I not remember this? Blood flow restriction. Raise your hands. Anybody on that? Had that? So that pressure typically starts around 150, and they leave that on for, minutes at a time, and they can go up even higher than that, around maybe 300, but that's sustainable. So that's not the type of pressure that we're talking about here with a tourniquet. We're talking much higher, much more pain associated with it. And again, about an hour with the tourniquet on, these impairments or the impairments in the nerve can last up to 6 months. The systemic effects, cardiovascular and respiratory, you see an increase in systolic arterial pressure as well as a central venous pressure, and that's temporary at the start of it. So it's going to go up, and then it's going to come back down again, but you might see a second wave of it as well. So just something to take note of if you are taking a blood pressure and so forth. If you have your equipment on you and you're taking that blood pressure, you might observe that initially, and then a second spike if you catch it at the right time, of course. Respiratory changes, simply that they're going to be generally observed when the next healthcare provider is taking off the tourniquet. So those aren't generally observed when the tourniquet is on. And then the hematological effects have to do with the platelets and the catecholamines that are released, and that's generally released due to pain response, and we see that in surgery as well as application of a tourniquet for an emergency. So the main concern here is that we have, again, if we take the tourniquet off, there's going to be this increase in fibrolytic activity, increasing that bleeding, which is what we don't want to have happen. So leave the tourniquet on so we can avoid that rush of blood that may produce if we take it off before it's necessary. More systemic effects here, metabolic. Mentioned this in terms of we're moving from an aerobic to an anaerobic type of energy system, and glucose and lactate and pyruvate and lactate to pyruvate ratio is all measures of factors of blood agents that are going on to kind of give us an idea of where the tissue is and getting what it needs for the situation at hand. But overall, we have a decrease in the oxygen, which means glucose is down in terms of being utilized, and then the increase in lactate with a decrease in pyruvate leads to that increase in that ratio. The bigger indicator is when they do get to a facility and they can take a blood test and look at the actual factors within the blood is the glycerol, is a component of plasma, and that's a key indicator that the person has actually experienced cellular death. So we can't say, looking at a patient, oh, you're experiencing cellular death at this level. They have to, of course, have the blood test to identify how much cellular or tissue death has occurred. And temperature-wise, it's a gradual increase of about 0.5 degrees Celsius every 2 hours after application of the tourniquet. And so that is a reduction in heat, an ability to lose heat, so the temperature is rising within the body. Did it go? There we go. Okay. So kind of wrapping up what that all means in terms of key points for a tourniquet is most external hemorrhage situations, severe bleeding, can be controlled with direct pressure, and that's where we want to start with, and packing, and if you have a hemostatic agent, including that in that process. Around 2 hours, and this has also been assessed with surgical procedures, is they have a 2-hour cutoff where they're going to occlude and basically apply a tourniquet for surgical procedures, but they're also going to remove that around that 2-hour mark and to ensure that they don't lose that tissue and have cellular death occurring. Prior to shock, that's a big one. Application of a tourniquet prior to shock. If we can, that's the best method, is to avoid having the patient go into a shock state. At that point, the blood loss is often associated with the state of shock, so it's telling us they've lost so much blood that they're already in the state of shock. We, of course, need to address the situation is the uncontrolled bleeding and apply that. The tourniquet pain is intense. Those of you that are gonna be joining our workshop will actually put them on yourselves and others and get to experience what that feels like. And we're not in any other pain going on with any other trauma to the body, so we're very focused on, oh, that's really, really tight right there. But we need to consider that patients may already be in an intense amount of pain, and this is just another thing on top of that. So thinking about how we can calm patients, we all have our own skills and how we work with athletes or other patients in settings that we are to help keep them calm in these situations where pain is a big factor. So tourniquet application, moving more into what do we do to actually apply this? Well, in the limbs, you would apply a tourniquet 2 to 3 inches above a wound. So you don't want to go directly over a wound. You don't want to go below the wound. You want to go 2 to 3 inches above it. You also want to stay away from applying it over joints, such as the knee and the elbow. And that's specific because when we're looking at limbs, that's the center point here of where essentially that limb would be. We wouldn't be able to do a tourniquet up at the junctional area. And then if you can, expose the skin so you don't get any slipping of that tourniquet, and tighten it to the point that that bleeding stops or ceases. And then, of course, do not remove the tourniquet. And effectiveness of the tourniquet is not so much indicated by a loss of a distal pulse or an absence of that. It's more of watching where that blood source was coming from and identifying, oh, it's slowed down immensely, a large amount, or it's completely stopped. And that's the success that we're looking for, is that it's stopped and ceased. You can apply it to yourself, which is great. You know, maybe you carry it around in your pocket like a mask these days. You can apply it to yourself, can apply it to others. You can apply it over clothes again, but if you have the option to take it off, if there's time there, we don't want to compromise time. If we need to be more active in putting it on, then go ahead and put it over clothes. Tourniquets hurt, I'll emphasize that again. A second tourniquet may be required, so if you have a second one on hand, it may be required, but you want to do that more proximal. You don't want to go distal, you don't want to go over the top of it. It's going to be applied proximal to the first one. We have this one video, sorry, that'll show the application of a tourniquet, and this is what we will be working with in the workshop and on yourselves and your partners as well. So going again 2 to 3 inches above a wound site, applying around, and it's got Velcro to it, so you're gonna hook it through the loop or the hoop and then pull it as tight as you can before you anchor down that Velcro. So you don't want it on there loose, you don't want it slipping. You really want to get as much of a pressure started as possible. And then you'll use this windlass system to turn and create higher pressures. So you're turning and turning and turning, and you're watching that source of bleeding to see, are we starting to slow? Are we getting slowing down of the blood source? Are we seeing a sensation of it in terms of stopping blood source? And then kind of stopping at a certain point, hooking that windlass system in there, and then writing the time. You see this individual writing the time of application. So all those, 45 minutes post, 2 hours post, 6 hours post, it gives the next healthcare provider an idea of how long that tourniquet has been on. Here are just some examples of different types of tourniquets. There's quite a few out there on the market. The CAT is what we're going to be providing you and working with in the next few days, or a couple of days. But there's others. The important thing is to note what works best for you, what's simple, what's less complicated. There's one in here, the SAM, that has a little prong system that if you don't get it at the right angle and the right pressure, you can't get those prongs to activate, and then you're delaying time. So it's really about what, if we come to the workshop and you practice and you go, oh, this is really easy one to use, I like this, and you have, of course, you're walking out with one from the workshop, but you can also go purchase more and use those for training of other people because then you're familiar with them. But if you've used others in the past that work for you, here's another list of non-pneumonic ones that you can choose from that all are appropriate. Some, maybe it's a cost situation for you or your school if they want to purchase a bunch of these and have them in sites around the school for response kits and so forth, but some to look at. There's also the pneumonic limb tourniquets where you actually can see the pressure and you're using air and pumping up to get to that point, but it's not a matter of hitting a target, it's a matter of stopping the blood flow from happening. So whether you have that dial to look at or not, you really want to just be watching the wound and looking for bleeding to stop. Okay. If you have bleeding in children, based on their size, most of them you can use the adult tourniquet and it works just fine. If you have really small, an infant or a very small child, a tourniquet's going to be too big and it's not going to be effective within that. So you're going to focus on direct pressure as much as you can and waiting for advanced medical care to arrive. For those large, deep wounds, again, wound packing best and always performed first unless you come upon a situation and from your training and experience, you jump right into a tourniquet, you make that call at that point. So there's some frequently asked questions. Impaled objects, we've all worked with, or not all of us have worked with them, but been trained on, how do we respond to an impaled object in the tissue? Keep it there, stabilize it. If the wound is that point, we're going above the wound, applying that tourniquet. Improvised tourniquets, yeah, maybe you don't have one of those brand name tourniquets on you and you're in a situation where packing and pressure is not working. If you need to improvise, you can. It's just we need to try to stop the bleeding in some way. Loss of an arm or leg, that's most of a myth there. Again, a lot of it has to do with the trauma and the cause of the trauma other than the tourniquet. The pain, yeah, it's painful, unfortunately, but it's better to have pain around than not to be alive and not being able to experience that pain. And then there's other questions that will pop up, and we'll get to a Q&A session here in a moment and answer those for you. So in summary, use the ABC, activate 911, find the bleeding, compress, pack, pressure, tourniquet as needed, and then wait for help to arrive. If you want more information, stopthebleed.org is the website that provides much of our resources. Again, we went a little bit further into the literature there, but the message is the only thing more tragic than a death is a death that could have been prevented. So if we are out in the field in areas where severe bleeding, hemorrhage, uncontrolled hemorrhaging can happen, and we have the skills to respond, we should be responding in that case and hopefully preventing a loss of life at that point. So here's our references. And I thought we had a question slide, but maybe not. Can you go back to the next one down? Yeah, perfect. And you can put it on display. So I don't know if it's on. I'll just go ahead and open it up for Q&A. I don't think our helper, oh no, they are there. Well, they'll be passing around the mic, so if you want to raise a hand, we can flip-flop between Valerie and I in terms of answering the questions. We'd love to have questions, too. It's hard coming after lunch. No. Oh, we got one.
So is the limit for tourniquets, would you say be 2?
I'm sorry, say that again a little louder.
Would the limits for tourniquets be 2? Like we shouldn't use more than 2 tourniquets at the same time?
Oh, the limit? Oh, that's a really good question. I don't recall reading any more than 2 at that point. I don't know if you...
My guess would be if you've put 2 on and you haven't stopped the bleeding,
Yeah.
you probably haven't cranked them tight enough, right? So I would go back and run that windlass a couple more turns on each one.
Yeah,
But
yeah.
I haven't seen anything about needing more than 2.
Yeah. The literature I read hasn't mentioned applying more than 2 to go on, but definitely checking your work in a sense of have you applied it correctly? Is it tight enough? And they may be hollering at you to like, no, that's enough, that's enough, that's enough. But if we haven't met the goal of it, we still need to go further with it. So,
Thank you.
Yeah, yeah.
What is the current recommendation on use of tourniquets in unconscious patients who are bleeding out?
I'm sorry, where's that at? Oh, you're right in front of me. I'm like
So,
looking
so-
all around like,
Yeah, I'll just repeat
where's
that.
Sorry.
What's the current recommendation on use of tourniquets in unconscious patients who are bleeding out?
The literature is the same regardless whether they are conscious or unconscious. You, of course, are going to check for breathing and airway and so forth, but you're doing the whole body scan. So if you are the only person, best thing is to, of course, open the airway, get the heart going, but if it's just pumping out, we also need to figure out how are we going to balance these two that are contradicting each other at the time point. So if you have extra people, that's the better route, so you have more people to help.
And in fact, it might be easier because it does hurt a lot, as she mentioned, and they won't be fighting you. And so you won't be so scared to crank it down one more turn, right? Because they're not going,
punches
"Oh," and you,
gonna come.
right? The caregiver and you, "Oh, okay, right? If they're unconscious, you probably can get more pressure and not worry about it as much.
Yeah.
It's probably
yeah.
more effective.
Yeah, so good question though.
So no mention of pressure points. Just kind of curious if that when that kind of stopped and not supported by studies. I'm guessing.
Yeah, I think when it comes to compression, the idea is that it is more effective to have more pressure directly over the wound. So if you were to provide pressure on a pressure point, for example, over the femoral artery for a leg bleed, in order to do that, you've probably got to take one hand off the direct pressure directly over the wound to do that. So if you had two people, absolutely go for it. But if it's just you, it's probably more effective to pack the wound and provide pressure directly over, where the lacerated artery is, if that makes sense.
Yeah. And sometimes it takes, you got to put your whole body into that. So if you've got a wider base of support, you're not getting as much pressure versus just over direct one, and you're leaning right over that, putting all your body weight into it.
Yeah, you're thinking two-hand CPR arms,
Yeah.
like you're doing the down
Yeah.
and stopping.
And it is exhausting, just similar to CPR. It's exhausting to hold that pressure because you need to be consistent with that amount of pressure to see actual results occurring. If we're letting off every now and then we're not being very efficient with what we're trying to achieve at that point. So, good question, though.
Any other questions? Last call. All right. On behalf of the RMATA, I want to thank our presenters for their presentation today.
And I have just one announcement for the conference. If you register for the banquet and have not selected an entree choice, please see someone at the registration desk to do that. So that's the